All right, thank you, Andy. So just a couple of reminders. *2 will unmute your line, and we encourage you to do that and have, interrupt and ask questions as things go on. This topic, as Shannon I'm sure will mention, is pretty dense, and there's a lot of moving parts to this. So we encourage you to unmute your line and participate in discussions and ask questions. I encourage everyone to visit the external SharePoint, which is where we post the webinar recordings, and the presentations are always there and available, as well as any resources that Shannon shares are available there for download, as well as in the bottom left corner of the webinar. For the Flex coordinators on the line, we really do appreciate your assistance with forwarding along the COPD assessment. We've gotten great results on that, and we ask for whatever assistance you can continue to provide to forward that on to your hospitals and pulmonary resources that will close on Friday the 21st. We appreciate your assistance with that. And I think those are all of my housekeeping items, unless I'm forgetting anything. Otherwise, Shannon, I'll let you take it away.
Thank you so much, Caleb, and welcome everyone. I'm happy to have you join us this afternoon again for the Learning Collaborative Week 5, Success in Healthcare Transformation. Specifically today, we'll be talking about the return on investment to value-based care. Thank you also to the National Rural Health Resource Center, who focuses on these topics and gives us this opportunity to have this platform to speak about this issue. As Caleb mentioned, this is the 5th in the series of 6, and what I would like to say is that the first 4 were really looking at the landscape of transformation in almost literal terms, what we're seeing out there that's affecting transformation or the result of or creating transformation. What this particular webinar is to focus on really a shift about the application and action in the transformation landscape. This particular focus will be discussing knowing the value, and then of course what the return on investment is for changing to this type of value. So what I'd like to do is help shift the context a little. In the beginning of the first 4, we really talked about CMS having a compelling reason to transform from volume to value. You know, that compelling reason is really about bending the cost curve of total patient spend. That's not going away. It's moving pretty rapidly, and we know that actually that compelling reason to transform leads the country in influencing healthcare payment reform. So not only is Medicare having a compelling reason, but they're opening the trail for other payers, insurance plans, health plans, to engage in the very same activity. And so responding into that context, the important thing is what value do rural providers offer to CMS and other payers? We've often focused on the value of what we provide to our communities, but the people who are buying them are the payers on behalf of the community, and they tend to speak a different language than providers do. It is important for us that we know and can demonstrate what the value rural providers offer to CMS and, of course, other payers. Following on that theme of knowing your value, which equals success, population health, prevention, and wellness is sort of the springboard for transformation and entering into the activities to see the results of transformation. We also talked a whole class on that primary care services help flourish, actually grow under population health programs. This is important because rural providers are really good at primary care. and they will benefit from engaging in population health programs. They provide a value. They do this well. They're virtually integrated, especially those places that have critical access hospitals that own rural health clinics, or any hospital that owns rural health clinics. They are well positioned to succeed in population health prevention and wellness. That probably is the least heavy lift of engaging in transformation. So I see it as a great opportunity to find a solid platform to engage in transformation. Lastly, last week talked about hierarchical condition category coding, and that really leads to the bigger conversation that when we are being measured for value, we are specifically being measured through claims data initially, and then publicly available data otherwise. So even though we may think that we are high quality, that we do a lot of quality work and compliance, if it's not demonstrated in a public space and in connection with claims payment and total patient spend, nobody really cares. I mean, yes, they care, but they're not using it in order to measure your value and their efforts to bend the cost curve. So pay for value is the future, and our data must reflect in order to get paid. It must reflect our values. So I think that is probably one of the most powerful things to think about, is that if we are not telling our story through data, then we're not telling our story. And if we don't tell the story of value, we are going to get left behind. Next week will really be the discussion of all the changes that are happening, mergers and acquisitions, and the things that are offered in the landscape as a result of these this context that we're talking about now, the result of transformation. So just can't say enough about specifically the documentation under hierarchical condition category coding. It is important that we tell our story, and we tell our story through data. The good news and the value is shown there, and if we do this first under the CMS transformation in any form or fashion that makes sense for your providers, this bleeds over into all the work you do with all the other payers. It helps you create a culture of demonstrating that value and having the ability of everyone else knowing that value. It's then written in your data. So the story in the data is just probably one of the most important things that we've talked about. So this leads us to the point of really how delivery is formed by a shift, sort of a tectonic shift in the way we're delivering care today. That's a result of the way we're getting paid today. And unlike the precursors to what we're dealing with today in payment reform, those things of PQRS and meaningful use, we still thought the same way, we still delivered the same way, we still paid the same way, but we had extra work. And in the middle of a paradigm shift, we can't continue to do those things the same way. Delivery changes after payment changes, or drive payment changes. And so I dub this as a paradigm shift. It's written as a definition of an important change that happens when the usual way of thinking about or doing something is replaced in a new and different way. This discovery of the shift will bring about a paradigm shift in our understanding of evolution. It just gives the context of what we need to speak about next. So we're really in the middle of a paradigm shift. Yeah, I thought it skipped one. Sorry about that. And it's interesting. So I was watching where you see people talk about changes. And under Becker's hospital review, there was an article by an information technology person that attended the Becker Hospital conference. They were in a sort of a shotgun round where CEOs of hospitals each spoke in bursts of information, And this is sort of the summary of what this specifically IT person said in his observation of watching this shotgun round. He said, healthcare providers are moving from a traditional strategy of buying and or selling hospitals and simply providing care to a new and more dynamic strategy that focuses on leveraging the platform they have in place to create more value and growth via new and often more profitable streams of revenue. So what that says to me is, number one, of course, under the paradigm shift, it means we're thinking and doing in a different way, but it also says there is great opportunity under this change. And there is apparently a host of CEOs that are engaging in this. My guess is those CEOs are larger because their opportunity in using infrastructure that they have gives an ability of an easier return on investment. But nonetheless, this was across the landscape of hospitals in this middle of transformation. It really spoke to me. And so under the discovery phase, which was part of the definition of a paradigm shift, I wanted to state some things that are happening where we really are that are really framing this shift, either in a positive or a negative way. The first thing is that, I've talked a lot about payment reform and delivery reform. The truth right now is that how you get paid is influencing how you will deliver. Not the reverse of that, where you change delivery in order to get paid differently. This is a good and a bad thing, but it sometimes puts some confines on the opportunity for delivery change, or it gives less options, which could be a positive thing. So that's just a statement that payment reform is defining delivery reform, and I'll talk a little bit about that. But in short, it's talking about, again, what that Becker review said, the opportunity of new revenue streams by new delivery. The second thing that's interesting is that you don't really see an end game for delivery, so that creates a lot of chaos. Well, if they want us to do X, then how do we actually adopt that into our own culture? Size, location, where you fit in the spectrum of care delivery or the continuum of care delivery creates no clear end game for anyone that wants to dip their toe in transformation or get pushed into the deep end of transformation. The reality is there's not really a clear end game on delivery. It's up to us to find that, to find the way. And so that makes it very interesting. It's an added discovery to just the basic discovery of transformation. And then specifically for rural providers, we don't see an absolute end game, even in the payment reform side of it. So I was fortunate to attend the NRHA national conference and heard Seema Verma from HHSC, as well as Tom Morris from Office of Rural Health Policy. And they both spoke that there is some coming opportunities for rural. However, they did not say that they would not expect that everyone that bills Medicare under Part B in some form or fashion will not be subject to measurement of cost and quality. So what's important to note in this is that even though there's opportunity for rural, it's still going to be under the confines of measurement of cost and quality by CMS at least, if not other payers as well. And the acknowledgement or tip of the hat from both of those speakers that, yes, there are unintended consequences in deploying this large, massive effort across the whole care continuum. There's not an absolute clear payment methodology that's easy for rural providers. So that creates yet more trepidation on engaging in jumping into the deep end. And then to add to that complication is that there is minimal alignment across the payer spectrum. What I know when there's low low volume providers, which means very narrow margins, and also slimmer infrastructure, is that variation in the clinical delivery creates resistance in engaging in change, because and to say that in a plainer sense, that variation of Humana saying you're going to do an annual wellness visit this way versus Blue Cross saying you're going to do another annual wellness visit this way, and then Medicare saying yet another. You're always going to answer to who's your most important revenue stream first, and all of them are in chaos. All the payers are also in this payment reform change, and this measurement of alignment, or this alignment of measurement, really hasn't happened. It's not to say that you could adopt Medicare payment reform and then know that that 100% is going to carry over to the others. So and probably most rural providers have been very good at adapting to say, okay, well, we know the top 5 most important payers, Medicare being the first, and X and Y being the second or third, and knowing how important the change is for any one of those delivery pieces to their revenue stream. This is creating a lot of white noise or ground clutter across that alignment of the payer spectrum in this transformation. So it also creates a bit of unease, again, in engaging in the transformation piece. So discovery phase is creating chaos. There's a lot of chaos there, and that creates other problems. It also creates other opportunities, so we're going to talk a little bit about that. And I put framing the shift. This might also be more about contributing the shift on this slide, but number one, so this is really talking about the context of engaging in all of this and knowing your value of all that you do as a rural provider. Is difficult because of these things. First of all, there are multiple payers engaged in it. Second of all, and it looks like my connection has lost some. So I'm on the phone. Caleb, if you'll let me know if it's not moving when I try to move a slide, that you can, it's reconnecting again. Hold on one second, sorry.
No worries. We're on framing the shift, number 10. Okay,
very good. It's loading right now. Okay, so very good. So sorry. So on number 10, the framing the shift, is also contributing to the shift. Multiple payment methodologies. It's not clear, and it's certainly hard to do an analysis of all of those, and it's very overwhelming, especially for rural providers, to engage in one and know that it might or might not be a lasting one, because you're going to take all your efforts and put into it, and if it only lasts 1 or 2 years, then that actually creates maybe a consideration that you have to consider the value of engaging in it at all. So both of those in transformation, the multiple payers and multiple payment methodologies, are both creating some resistance. Change in demographics is happening outside of transformation, but it's affecting transformation. Number one is that as we have younger people moving into health plans, with the opportunity of technology, creates a different type of payment plan that's delivered. So we're seeing some telemedicine and some remote control, remote access and remote monitoring that is being driven by a technology-savvy consumer. Converse to that, the baby boomers entering into the particularly Medicare and Medicare Advantage plans, is that they are demanding, and by need specifically on the disease states, they have a high amount of chronic disease states, multiple chronic disease states, that those are actually demanding more face-to-face time and need it. So from a delivery perspective in a practice, how do you manage both of those? It's really pulling you at both ends of incorporating for this, but having a change in consumer demand that's polarized by two very different types of consumer need. Adding to this this frame of this shift is that Medicare timelines, they are very aggressive in adoption, pressing you not to take a slow and steady decision, but a pretty aggressive decision. That creates resistance. Then the cost of change really is probably underestimated, and I have a slide that really talks at length or a little bit more in depth about the cost of change, but there is a cost that's probably not necessarily even wholly recovered in a return on investment pro forma. So there's always part of that concern. Just the emotional effort for the whole entire community to make that change is a lot. And then I spoke of technology from a consumer demand, but also from a delivery perspective. We've certainly, lived through the EMR adoptions. We've seen some failures of what the reporting of the EMR have supposed to be doing on quality measures. And that in and of itself is again, creating this very unstable platform that we're asked to step on. And finally, what I find interesting, and rural providers are very good at this, which is relationships. But the relationship and the type of the relationship is really changing. Next week, I'll talk a bit about how we see payers actually engaging in relationships with pharmacies or chains or systems in a different way that we haven't seen before, which again creates an assessment and a consideration of what does this mean and how can we engage in it. So stated that this paradigm shift is pretty significant in what the broad scope of how it's affecting providers and engagement. This should be sort of a summary of that. It's a symptom that we're already in the paradigm shift. Certainly we're seeing changes from fee-for-service to value-based care payments. We're seeing delivery from reactive transitional care to proactive managed care. And then we're seeing the focus of being from provider siloed care into actual patient-centered care, which affects the whole entire both payment and delivery reform efforts. Again, this growing divide of demographics and expectations and the everything in between of baby boomers and millennials and affecting the consumerism demands on the delivery system, and then affecting also the payment system. And finally, those new types of relationships and mergers and acquisitions. It gives cause and pause for rural providers. Obviously, the results of all of this is that there is a paradigm shift, and it's creating a lot of providers to be very overwhelmed. My son calls this analysis paralysis. You get to a point of it's almost too much to make the decision, so can I not engage in this at all? In the field, for the last 5 years, I've probably talked to thousands of providers and practices, and everyone, of course, is very concerned about engaging, but there's always been time and opportunity and circumstance to do an analysis to determine what is the right vision, what is the right plan, or the trajectory to engage in this. And unfortunately, some of the response of that is that there's a big resistance to change, which might result in missing opportunities. So, one of the things that I think under paradigm shift is that we accept that change is part of a static as opposed to a passing thing. For a long period of time, we're going to have change. Meaningful use has been here for several years, and the projections in Medicare are well past 2026 of just what we're starting into, the ACO possibilities. Those have been dubbed accountable care organizations as a payment methodology, are actually being dubbed as precursors to transitional payment methodologies. So, when you're thinking, we're going to get into an ACO, and then somebody says that's transitional, you're thinking, what? So I think one of the important things is to think about the paradigm shift as actually part of the norm, that there's going to be a lot of change. And so how do you actually manage that is an important piece of the future. This is the following story of that story from Becker's Review that I spoke to you earlier. the IT person who was observing this rapid response from hospital CEOs. And in his observation, he said, simply stated, the healthcare delivery system of today will increasingly leverage the platform and resources that they have in place to become a hub for both healthcare and health in the future. There is a level of urgency to move quickly. Many feel that if they don't expand the role they play in both health and healthcare in their community, someone else will step in. His analogy to this in another industry, looking at IT in particular, iPhones, is that if you think about changing from being a product to being a platform, rural hospitals really do good at that already. They do well at that already. They are a platform. They probably have not been able to exercise that platform in a greater way. But I think through some of the payment methodologies, there is an opportunity. So moving from being a product, perhaps, being four walls of bricks and mortar of a hospital or a facility of practice, that they combine those two and leverage them into being a hub of delivery for health and care in their community. Perfect example of that rurals do exceptionally well, and I've seen a lot in Texas, are wellness centers. They actually added on wellness centers with occupational therapy, saltwater pools, the ability to have physical therapy there on site, adding that a beautiful restaurant that senior citizens can come and eat healthy. Those things actually changed from being just a hospital and practice or clinic practice into being a platform. And so I think that watching the ability of standing on the platform and having the opportunity of engaging in new changes while still standing on their platform is the opportunity for rural health care. So that all turns to the point of you have to know your value. And in order to know your value, you really want to know what your investment is in demonstrating your value. So I think the very first question of that is how big is the investment? That goes and speaks to what I just said, is what are we investing in specifically in engaging in this transformation? What can we springboard from this platform that we already have in place? And every rural community, of course, is different in what their platform is. But the consideration, and I won't answer these, but I know in the field as results that these are questions that people ask in the investment of engaging in a payment methodology or a particular service line that they need to expand on. And maybe the service line example will be the population health service that we've been talking about all along. So what is the cost? What is the risk? And the cost is comprehensive, not just in the delivery, but the cost of adopting this and incorporating it into your whole system. The other would be risk, and the risk is even for, we use the terms in payment methodologies, upside risk and downside risk, which means, winning and receiving revenue to losing. I would challenge to say that the downside risk of not participating, it needs to be very much investigated in engaging and understanding what your investment is so that you can know what your return would be. You need to really measure, if we don't engage in X or Y, in the consideration, what is the downside risk of not engaging? Certainly there's also a technology adoption, and I mean that far beyond the EMR component, but all that engages in training and adoption and the richness of that adoption to remote monitoring, telemedicine, and then even those telephone visits that are becoming approved. One of the things that is new in payment methodology is analytics, and probably rural providers in-house wouldn't necessarily have analytics, but it's going to help to have somebody on your team or someone connected to you that has a good sense of the analytics and what your data is saying. Analytics are where everybody's reading and asking the question, and if you don't tell and they don't ask, then what are they going to ask and tell about you? That's sort of a circular question, but I think the point is, if you're not telling your story, they're going to be asking questions that are not applicable to you, to the rural provider, to the low volume provider. So I think analytics on your team is really critical. Also, the human capital of staff and the strain of change, there certainly has to be some investing in managing that change in two ways. One, of course, is the emotional burden, but the other is it needs to be really clear that that the change is not an addition to the work that you're doing, but it's a changing of the work that you are doing. What we saw a lot in meaningful use and PQRS is that lots of people did the same work they did every day and then took on another job, and the burnout rates were high, and that won't sustain success in in true transformation. So I think that supporting your staff and understanding some change management is really important in making sure that the understanding and the investing of the job helps them either to take it on or incorporate it so that it doesn't add more work but a different kind of work is really important. The other is the investing in relationships, doing narrow networks, and understanding how that you get paid based on having referrals to narrow networks. That means people who you refer to and people who actually give your patient back to you in that spectrum of care delivery that you're not actually able to serve is very, very important. And there might be a cost to that, but there's certainly some time and effort that needs to be in investing in those relationships. And then to end all of that, there really is an investment in the actual change of the whole program. It's a different feel for everyone in the system to understand that you're changing from a product to a platform. It's a great opportunity, and I think it's a refreshing one, especially for rural hospitals who have been under this burden for such a long time of trying to deal with change and taking on more, and then not seeing the opportunity based on all the chaos that we've seen out there. So with this, what I would like to say is this is a very small fonted slide, and the good news is that we're going to shift over to an Excel spreadsheet. But before we do, I just want to explain to you what this is. You'll see some basic categories of codes, and then a description of those codes, and I've also identified the billing codes that are going beside them that are all about population health opportunities. And then we also included the frequencies in number and in description. And then there's some appropriate payments based on what, and in the spreadsheet, I believe that I've also included the sources for all of these codes and payments. This is for use and not absolute, so it's really part of an exercise, but the total of new opportunities is, in this instance, based on 1,000 Medicare beneficiary lives. If you were to do all of this service on population health and you had 1,000 Medicare beneficiaries with a little bit of application of epidemiology on the number of patients who might actually be able to do this, is about 1.3 million. That's upfront revenue generated. Now, there are costs associated with this, and we just put in there RN, and actually this moved over to the other side of the circle, but the actual medical assistant and or care coordinator in portion to manage these types of services. That still gets it to 1.2 million in service delivery of population health. Now, I'll caveat that, but this is a very optimistic look, and its entirety. So with that, Caleb, if we could move to the Excel spreadsheet now where I can share my screen.
Absolutely.
Okay, and it's coming up right now. Should be up on the screen. And can you guys see it now?
There we go.
All right. So I'm going to work on my desktop, so let me know if it doesn't show up, Caleb. We'll do this together. So a little bit in bigger font, hopefully for you to see. You can see that that we have these population health services on the left-hand side, and I included both the G codes and the, I believe, HCPC codes, the frequency, the actual, also frequency and number for calculation purposes, and then the cost. What I did was thinking about implementing this program in year one, and so I call this a simple program or a goal to start with in the first year. And so you can see on row 1 that I gave an expectation out of 1,000 lives that maybe in year 1 those providers would probably only see 30 people giving that initial exam. You can give an annual wellness visit within within 11 months after that IPPE exam. So you could actually have both of those in one calendar year. I thought that perhaps you might have another 60 getting that same one. It might not work for all of them. And then in that same year, you would still have probably 91% or 910 out of 1,000 getting that subsequent annual wellness visit. So you can see the idea of this calculating the number of for projected revenue, but doing the annual wellness visit or IPPE as one, then always doing taking the opportunity to advanced care planning. In this one, we put that probably you could do advanced care planning about 300 or 30%, and then a 30-minute one at 10%. We also felt that there's probably 20% that are actually eligible to be in chronic care management, and so you would get 20% of the chronic care management and then 20% of the non-complex. I think that probably this doesn't do a fair job, and this one doesn't actually have coding in the background, so I'm not going to change it, but I would think that we could probably also add the same amount, 20% on, I'm sorry, I did do that correctly. So there's 20% that actually have the first visit, and then there's 20% that are in the program monthly. So that's correct. And then you do a mini COG or a fall risk screen. Every 100% of your Medicare seniors that you see should have that offered to them. So that's sort of how that went, and that's what you can see at the bottom of if you did this small program, depression screening, remote monitoring, and tobacco use counseling. Most all of those are done at the beginning of your annual wellness visit. So if you did a small program and were able to get it up and running in the first year at 100% for 1,000 Medicare beneficiaries, that would be about $711,000, and then minus your care coordinator and Medicare Advantage. I'm sorry, I thought MA medical assistant. You would still be at about $614,000. Now, what I know is that working in practice transformation over the last year, some of the ones who struggled and weren't able to engage wholly in the first year probably only got to 20%. So I did a calculation here of 20% in year one for this number of 1,000 lives doing those services. So your return still is $122,000 in profit of these services. What I also did for you, and this will be uploaded into the portal. So there's our resources, and I actually did one that all you have to do is change how many Medicare beneficiaries you got in your program. So for all of you that have been with us since the beginning, I ask that you reach out and see if you could find Medicare beneficiaries. How many of them have had annual wellness visits? In doing that, you can actually enter into this number. I picked 652 Medicare beneficiaries in a community. So you can change that number. It should read through the whole entire system on this yellow column. So if you had 652 Medicare beneficiaries in your community, $463,000 billing, 366 in revenue. If you got 25% in that first year, that's $91,000 still to your bottom line. So it's a good number. You can change this one, column L 37, and I'll probably go back and highlight that one for you, but that one you can change as well as this one. So that's for you as an ROI calculator to be able to change those numbers and then see what the return on investment is just with those two small tiny pieces. So I'm going to go back and see if I can see if there's anybody have comments or question on those. I'm not going to stop sharing my screen, but I'm going to move over to looking at the Learning Collaborative Adobe Connect. If anybody wants to put anything in the chat box or speak up to or unmute your line and give us a shout out. Any questions? I don't see anybody typing. Caleb, is my screen frozen, or can you see if there's anyone?
It doesn't look like anyone's typing anything. Star 2 will unmute your phone line if you do have any questions.
Very good. Very good. So I won't belabor it, but I think if any of you have any questions, of course you know where to find me. Feel free to reach out to me, and this spreadsheet will be posted out there on the portal. Terry, any thoughts or comments you'd like to add since you're joining today?
Yeah, I agree with all your points, and I think this could be very, very useful for a hospital in particular that might be contemplating whether they're going to move into an accountable care organization. I would agree with you, Shannon, that there's a tremendous amount of uncertainty out there, and I hear that wherever I go, as I'm sure you do, and probably the folks on the call do as well. But one of the things we're absolutely certain of is that we are moving into this different payment system. And probably the single most important thing to begin with is kind of what we're doing today, and that is we need to be able to educate and to build the awareness of our hospital boards, most of whom really don't understand these changes. Secondly, our hospital physicians who really don't understand this and are generally a pretty unhappy group at this moment, high rates of suicide, et cetera. So we have physicians out there, we've got nurses, and just in general, because I don't think they understand what is happening and ultimately what is best for the patient. And that, we can look at the finance, we can look at, a lot of different aspects here, but I think ultimately it's going to be, is this going to be good for our communities? And I think everybody on this call, we need hospitals, and they're terrific in that regard, but we're advocates for our communities and the patients, et cetera. And what we're moving into, those of you that are in public health, this is public health, basically. I've got a public health background, and so this is about keeping people healthy. This is about wellness. This is everything that we believe in that regard, but in many cases is kind of foreign to our typical hospitals and a lot of the providers that are out there as well, who have been kind of immersed in this kind of dysfunctional system that has paid for procedures. So besides the education part, I think the other really important thing is not to jump into accountable care organizations or to immediately move into value, especially if you want to be cautious. It's to start planning for the future and to be thinking about how are we going to engage our community? How are we going to do some of these things? How are we going to be very carefully moving across what we metaphorically call this shaky bridge into the future? And ultimately, what we want to do is to prepare and then move cautiously across that bridge. And at the conclusion, we're going to have this value-based population health system. But that's probably going to be when the payers get aligned in that regard. I totally agree with you on that aspect. And I think there is I'm very optimistic about the future as long as rural hospitals begin at least to get educated and plan to move across. But I think we're all extremely concerned that if they don't begin or start to build this awareness and start to calculate what's going to be happening down the road, they will get left behind. And in the new era that I think you're going to talk a little bit more tomorrow, which is going to have a lot of telehealth and a lot of other aspects here, new payers, disruptors, et cetera, moving in, it could very well be that the whole rural hospital model as we know it will be something, that it's in the past, So, if nothing more, let's get prepared and then let's move forward here. But it's not an easy journey, and in many cases we just need to be aware and to prepare.
Thank you, Terry, for that. I appreciate your comments and rounding that perspective out. Do any of you have questions? Anybody? As always, you can reach us either. My email's posted and on the last page, so you have the option to email me if you have any questions specifically on the spreadsheet. It'll be posted at the portal, and I think that we could possibly give you back 15 minutes of your day today.
All right, guys, just another reminder, *2 will unmute your line or utilize the chat feature if you have any questions. Otherwise, as Shannon said, we'll post the presentation, the recording, as well as the spreadsheet template that she created in the external SharePoint page. So please refer there if you have any questions. And as always, we'll see you back here next week, Wednesday at 2 p.m. Central. And hearing no questions.
Caleb,
Terry.
just one final thing. Again, I think as Shannon has told you, this transformation is taking place differently in some states. In fact, I don't know of any two states where it's identical. If you folks have a specific question about your state and want to give us a call, you're certainly welcome to call me here at TASC, the center, or contact Caleb. And I'm sure Shannon would be willing to. Shannon's worked all over the country as well. And we could help you get a better feeling, for example, of what is Oregon doing at this particular point. I was just in Alaska, and it's really interesting how fast things are moving in Alaska, which has been very slow to adopt any of this, but it's moving pretty quickly right now. So if you want some kind of special, help, don't hesitate to reach out to us.
Yeah, absolutely. And that goes for when we're starting to develop our action plan. So, we'd like to, based on the education and resources provided during the Learning Collaborative, we want each participant to develop an action plan, something that your Flex program will do, based on this Learning Collaborative. So when you start to think about what reasonable activities or actions, facilitating an assessment to your hospitals, reaching out to some of them, helping them complete that ROI spreadsheet, things like that are all reasonable things. So if and when you start to develop those action plans, and we'll get the template posted on the SharePoint page, and maybe we'll talk about that a little bit next week as well. We can absolutely help support some of those things, and we'll talk about the next steps and things on the next webinar as far as check-in calls and